welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
So we'll go ahead and dive into the epidemiology of vasoplegic shock. So its prevalence kind of ranges pretty widely between 5 and 50% of cardiac surgeries. The mortality, though, is fairly high at 25%, and it is associated with significant morbidity with increase in organ failure like acute kidney injury or acute liver failure. It's also associated with an increased length of stay in the hospital and ICU and prolonged mechanical ventilation times. There are various causes of vasoplegia. One is sepsis. There's other non-cardiac surgery-related causes like burns and trauma, and then pancreatitis. And then, like mentioned and alluded to, cardiac surgery is another large cause of vasoplegic shock, and that's the one we'll be focusing on mostly today. So usually we have a patient that has normal cardiac output, and they either have an increase in systemic vascular resistance or normal systemic vascular resistance, which leads to normotension. But in patients with vasoplegic shock, they have a normal cardiac output, but a decrease in systemic vascular resistance, which then leads to hypotension. Specifically in cardiac surgery, causes of vasoplegia are usually exposure to an extracorporeal circuit like ECMO or bypass, which that will be the focus of the patients in this study, or if they have dysregulation of vasodilatory modulators like nitric oxide. And there are some risk factors for vasoplegia in cardiac surgery, and these ones are like antihypertensives like ACEs and ARBs, or ones that affect the RAS system. Patients that have a reduced left ventricular ejection fraction also have an increased risk of developing vasoplegia, or if they have a longer cardiopulmonary bypass time, so longer time on the pump. And this is usually diagnosed with hypotension in the absence of a low cardiac output state. So these patients typically have a normal cardiac index, but are still hypotensive. They also should not have any signs of an infection or sepsis being a potential confounder, and also not be on any cardiac modulating medications or vasodilatory inotropes like dobutamine or milrinone. And there should also be evidence of tissue hypoperfusion, like an elevated lactate. So the definition of vasoplegia would be a MAP less than 60, an SVR less than 800, but a cardiac index greater than 2.2 or a normal cardiac index. And typically, the treatment for vasoplegic shock, first-line therapies are catecholamine vasopressors, like norepinephrine or epinephrine, and then adding on vasopressin if necessary. And then angiotensin II might also play a role in vasoplegia. And then refractory therapies include methylene blue and hydroxocobalamin. Looking specifically at these refractory therapy options, we have methylene blue, which works by inhibiting the nitric oxide synthase and guanylate cyclase, so it decreases the nitric oxide on smooth muscle relaxation. And the dose is usually 1 to 2 milligrams per kilogram IV push, and sometimes patients are continued on a continuous infusion, but that is still variable. Side effects associated with methylene blue are methemoglobinemia, urine discoloration, or even serotonin syndrome, but usually that's fairly well tolerated. And there is a special consideration with methylene blue for G6PD deficient patients, as this medication may not be as effective or could lead to hemolytic anemia. And that is not something that is always readily available, and the lab tests that may take a while to come back as well. Then hydroxocobalamin is a vitamin B12 precursor. It also inhibits nitric oxide and other inflammatory mediators. And this dose is typically just 5 grams IV over around 15 minutes. And the side effects associated with this one, again, are just very minor and usually well tolerated, but hypersensitivity for urine and sweat discoloration. And other considerations just with hydroxocobalamin, it is fairly easy to administer as the pack kind of comes all ready to go. The tubing is already set to run over the desired rate of 15 minutes. There have been some studies that have tried to evaluate comparing these two medications. This first one by Furnish and colleagues was a retrospective cohort at a tertiary academic medical center in June 2015 to December 2018, and they compared methylene blue versus hydroxocobalamin. And this was in perioperative cardiac surgery patients. And their primary endpoint was change in averaged norepinephrine equivalents 1 hour after administration of the intervention. And other secondary endpoints were change in time of MAP and norepinephrine equivalents, all ranging from 15 to 6 hours after treatment. There were 35 patients included in this study, but there was actually no difference in either outcome of average norepinephrine equivalents at 1 hour or secondary endpoints. They are associated with, both of them were associated with an increase in MAP at various time points, but only hydroxocobalamin was associated with a decrease in norepinephrine equivalents only at the 2 hour mark after administration. So again, this is a retrospective study, so that does limit the applicability of this, but it does add to literature supporting that either of these medications could potentially be used for vasoplegia. The next study by Graham and colleagues was another retrospective propensity matched cohort study from July 2013 to May 2020. And this one also included patients that received either methylene blue or hydroxocobalamin. Again, these patients were perioperative cardiac surgery patients up to 24 hours after cardiopulmonary bypass. The primary endpoint for this study was percent change in vasopressor dosage at 30, 60, and 120 minutes after the intervention. And other secondary endpoints were percent change in MAP, percent of patients with vasopressor discontinuation, and then ICU and hospital length of stay. And then lastly, inpatient mortality. There were a lot more patients included in this study with 142, but there was no difference in the primary endpoint. But methylene blue was associated with a greater percent increase in MAP and a shorter ICU and hospital length of stay. So this one, pretty similar to the previous study, but had included more patients. And this one actually showed more of a benefit towards methylene blue being more efficacious. But again, it was retrospective, which limits its applicability. Now for our current study, which was hydroxocobalamin versus methylene blue for the treatment of vasoplegic shock associated with cardiopulmonary bypass by Huryu and colleagues, published in the Cardiothoracic Vascular Anesthesia Journal. And the primary objective of this study was to evaluate the impact of hydroxocobalamin compared with methylene blue on vasopressor requirements and other hemodynamic parameters in vasoplegic shock in patients requiring cardiopulmonary bypass. So like previous studies evaluating these two drugs, this was a retrospective cohort, but it was done at a large academic medical center, and it did look at post-cardiac cardiothoracic surgery patients. And the intervention was methylene blue from January 2016 to August 2019, comparing hydroxocobalamin from July 2019 to June 2021. So this is kind of like a before and after study, as their standard practice at this institution was methylene blue for those first couple years, and then switched to hydroxocobalamin in the last couple. Patients were included in this study if they were adults and greater than 18 years of age, and they had a surgery that required cardiopulmonary bypass. And they also needed to have some form of vasopressor requirement, and they measured this in the form of norepinephrine equivalents greater than 0.2 micrograms per kilogram per minute. Patients were excluded for non-vasoplegic shock, so this would be like sepsis or cardiogenic shock. The dose of the medication had to be given within 48 hours of cardiopulmonary bypass, and their cardiac index, if it was less than 2, then they were excluded because they likely had cardiogenic shock. Patients were also excluded if they received both methylene blue and hydroxocobalamin, or if they returned to the OR within 48 hours of the original surgery. The primary outcome of this study was the change in vasopressor requirements over time, and this was measured at hours 1, 3, 6, 12, and 24 after administration of methylene blue or hydroxocobalamin. And they have listed here how they calculated the norepinephrine equivalents. Both norepinephrine and epinephrine were taken at face value, and then phenylephrine dose was divided by 10, and then vasopressin was multiplied by 2.5, which is pretty standard and pretty similar to what was seen across other studies. So the endpoints and characteristics that were collected on each patient for demographics or background, there was comorbid conditions, the American Society of Anesthesiologists physical status, preoperative left ventricular ejection fraction, preoperative medications like RAS inhibitors or beta blockers, surgical characteristics or other interventions, and then secondary endpoints including mean arterial pressure, systemic vascular resistance, or lactate, all measured again at 1, 3, 6, 12, and 24 hours. And then they had other clinical endpoints like ICU length of stay, hospital length of stay, and hospital mortality. Statistics for this study, since it was retrospective, they did not have a power calculation, but categorical variables were evaluated using a Fisher's exact test or a Pearson chi-square and then continuous variables evaluated using a student t-test or a Wilcoxon rank sum test. And to account for multiplicity, they also used linear mixed effects model to assess differences in vasopressor requirements, MAP, lactate, and systemic vascular resistance. And then they also adjusted for other differences like mechanical circulatory support, preoperative RAS inhibitors, and then duration of cardiopulmonary bypass. And then for the results of this study, 549 patients were evaluated for inclusion, and 429 patients were excluded. Most commonly, they were excluded for receiving methylene blue or hydroxocobalamin for non-cardiac indications, or they actually did not receive the intervention. And this left us with 120 patients included, with 43 patients receiving methylene blue, and then 77 patients receiving hydroxocobalamin. For baseline characteristics, on average, patients were around 60 years old. Majority were male patients that were white. There was a difference in the chronic lung disease between the two groups, with that being more common in the hydroxocobalamin group. And then in their American Society of Anesthesiologists class, most patients fell in the classification of 4. And I know this is probably something that we're not as familiar with as pharmacists, but the classifications for this range from 1 to 6, with 1 being a normal healthy patient and 6 being determined as brain dead. So with 4 being the most common, these patients were defined as having severe systemic disease that is a constant threat to life. So these patients were pretty sick. And then mechanical circulatory support was very similar, but of note, the preoperative left ventricular ejection fraction was lower in the methylene blue group, and they were also more likely to be on preoperative RAS inhibitors. Then for surgery characteristics, there was a pretty balanced different types of procedures. There was pretty wide variety, and it was even between both groups. There weren't really any differences between them. Patients did on average have almost around 200 minutes of bypass time, and that was not statistically different. There were more patients in the methylene blue group that did have redo procedures, which could indicate that these patients may have been a little sicker. And the procedure time was also a little bit longer in the hydroxocobalamin group. And then the patients in the hydroxocobalamin group also had a longer duration of circulatory arrest. So then going on to the interventions of these two groups, almost every single patient was on epinephrine and norepinephrine. And then a majority of the methylene blue patients were on phenylephrine. And then additionally, most patients were on vasopressin, but again, more likely in the methylene blue group. And there was a decent amount of intraoperative milrinone use, but not statistically significantly different. And patients on average in the methylene blue group did receive around 1 milligram per kilogram initial bolus dose, which is what is recommended. But a few patients did get a continuous infusion. This is usually around 0.25 milligrams per kilogram per hour. And then the hydroxocobalamin group, the majority of those patients received the 5 grams. And the patients in the methylene blue group are also more likely to receive the intervention in the OR versus the hydroxocobalamin group. More of those patients received them after the OR. And blood products were pretty evenly split between them as well. And then in terms of the primary outcome, this was a chart that was in the article. And so for box A, this was the primary outcome with norepinephrine equivalents on the left-hand side, and then the hours on the bottom line. And as you can see, the circle or complete line is the hydroxocobalamin, and the methylene blue group is the dotted line. The methylene blue group did at baseline have a higher norepinephrine equivalent requirements and compared to hydroxocobalamin. And this was statistically significant, but they also found that hydroxocobalamin decreased norepinephrine equivalents significantly more. But as you can see, they both decreased pretty similarly. And then in box B, which was a secondary outcome, looking at mean arterial pressure, again, the methylene blue group did start out at a lower MAP compared to hydroxocobalamin, but both had a pretty decent increase in MAP as the hours progressed, but hydroxocobalamin had a statistically significantly higher increase in MAP. And then for box C and D for systemic vascular resistance and lactate, there was no difference between the groups. In terms of the clinical endpoint, the hospital length of stay was not different, neither the ICU length of stay or hospital mortality. So these authors concluded that both methylene blue and hydroxocobalamin were associated with decreasing vasopressor requirements and increasing MAP, but with greater reductions of the vasopressor requirements in the hydroxocobalamin group. Strengths of this study, this was the largest comparative study comparing these two. It had the most patients that has been known to date. They also excluded some cardiogenic and hemorrhagic shock patients to really focus on the vasoplegic shock. And there were a wide variety of cardiac procedures that were included. Unfortunately, the study does have limitations. Was retrospective, and since it was a before and after study, there could be practice variations during those study periods where methylene blue versus hydroxocobalamin was utilized that may not have been known. And the methylene blue group did have a higher baseline norepinephrine equivalent, which is a confounding variable. And then methylene blue was also given more frequently in the OR, so maybe the vasoplegia was more significant earlier on. Lastly, this facility does not have angiotensin II on formulary. And as we discussed earlier, that may have been another potential option to treat vasoplegic shock. And lastly, there is a lack of placebo group in the study, so it's hard to determine whether or not the increase in MAP and decrease in norepinephrine equivalence was just due to the vasoplegia resolving on its own. So from this study, I think there needs to be more prospective studies comparing these two medications to really determine which one could be superior. Both of them have shown that they can improve MAP and decrease vasopressor requirements, but I think this study had too many confounding variables and differences in baseline characteristics to really determine which one is more significant or superior than the other. With that, here are my references, and I will take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.